Good evening, everyone. This is Umashankar from Marketing Department of Linex Pharmaceuticals, inviting all of you for this all important web. One mention of L-carnosine in the usage of alcohol use disorder. Before we go on to the subject, let me have a brief about our company. Linex is a very progressive and a very ambitious pharmaceutical company, which is ranked 13th in the neuropsychiatry segment. We are able to launch many novel products in both neurology as well as psychiatry at very affordable prices with our enterprising setup and network. Very recently, we also have started our international operations in Afro-Asian countries, and we aspire to be a dominant player in the neuropsychiatry segment. We also take very active part in academic collaborations and also in conferences in both the neurology as well as psychiatric specialties. And one of the part of academic outreach is regular conduction of this webinar series, which we do regularly. And we welcome you to this important webinar for today evening. And I also take it is my pride, proud privilege, and pleasure and honor to introduce our beloved speaker, Dr. Rajesh Nagpal sir. He doesn't need any introduction, but for the formality's sake, let me do that for all of you. He is a very well-known and renowned psychiatrist who is based at Delhi. Basically, he is a graduate from a postgraduate Institute of Medical Education and Research, Chandigarh. He is a consultant at Rajouri Garden in New Delhi. He is also a chairman on a section of Developing Nations in World Psychiatric Association. He is also director of Behavior and Neuroscience Academy of India. He is a Secretary General of Indian Global Psychiatric Initiative, and his contribution Indian Association of Private Psychiatry known to all. He is a past association as well and Society for Bipolar, both academic as well as clinics of psychiatry. With this brief remarks about him, I hand over the session to Dr. Rajesh Nagpal sir. Sir, over to you, and please.
I thank you, Mr. Umashankar. Thank you for your kind remarks. The topic is, I think, recent concepts in the management of alcohol use disorder. But Mr. Umashankar mentioned the caveat, it's about the role of carnosine in alcohol use disorders. So this will be delivered by Dr. D. Kurupkara Krishan. He has more than 10 years of experience. Currently, he is an associate professor of psychiatry and has done a stint of work in the Indian Navy. And we are very proud of our armed forces. So thank you very much for that contribution there. The only thing I wish to point out here is that much of the alcohol use disorder is known through the length and breadth of the country. This dimension of using an antioxidant for prevention of hepatic damage or treating hepatic damage is a newer dimension. We would love to hear the evidence-based medicine as far as not the animal studies or in vitro, but human studies and the efficacy thereof. Role of other drugs, both for prevention or the anti-craving agents, is well known, but certainly it will be nice to have a nice summary of that. So with that, without further ado, I would request the speaker to start immediately. Thank you very much, sir.
Good evening, sir. Thanks for the chairperson, Dr. Rajesh Nagpal, sir, for the nice words, and Linex Pharmacy for giving me this opportunity for the webinar tonight to speak about the recent concept of alcohol use disorder. And I warmly welcome all those who came for this webinar today. We are going to have a short outlook about the alcohol use disorder and the recent concept in the management along with the adjunct therapies. So before proceeding, I would like to highlight and outline my presentation. This is the outline of my presentation. The presentation slides will be process, introduction, history of alcohol, epidemiology, nostalgia, etiology, risk factor, theories of neurobiology of addiction, and assessment, management, and conclusion.
Can you please share your presentation, sir? It's not on the screen right now.
Sir, this is not coming up in screen, sir?
No.
Share the screen, sir. Yes, sir.
So now it's coming, sir?
Yeah.
It is loading, yeah.
Yes, yes, please.
Yeah. Okay. So coming to the introduction, highlights of alcohol and the ancient roots. So from festival gathering to the solitary struggles, behind every cheers there is a story of tears. So the journey from the cheers to tears reveals a harsh reality of alcohol dependence for joy of drinking and eternity like affection. So alcohol dependence is a heartbreaking reality for the many, begins as a toast and gradually spiral into the viscous cycle of addiction. Living the shattered life, broken relationship, and loss of dream in the vacant. So let's delve into the world of alcohol dependence and its recovery. Let's explore the journey from the use to the misuse and to the ultimate to the dependence. So coming to the epidemiology, in India, mostly the consumed beverage by the current alcohol users are country liquor or deshi sharab, accounts about 30%, and spirit or Indian made foreign liquor is about 30%. So according to the National Survey on Extent and Pattern for the Substance Use 2018 reveals the alcohol use in India is about 14.6% of the population between the age of 10 to 75, and it's roughly accounts 16 crores of users, and among most of them are males from the rural areas. So if you see the problem users, 5.2%, that is 5.7 crores are problem users. Among them, 2.9 crores are dependent users. This is not an individual one. This 2.9 crore families are getting affected. So, and it also highlighted that every one woman who consumes alcohol, there is 70 men are using alcohol. So before we start, let us reflect what is addiction and the disorder model of addiction. As we all know, the addiction is not simply a behavioral choice, but it's a chronic relapsing brain disorder. It is characterized by compulsive use despite of devastating consequences, the pathological pursuits of reward that hijacks the brain natural motivating system. It involves both physiological dependent in the form of compulsion and craving, physiological dependent in the form of tolerance and withdrawal, and psychological dependence in the form of compulsion and craving. The addiction produces a long-lasting brain pattern, brain changes, which leads to pattern of behavioral changes, the loss of control, salience, relapse and recurrent, withdrawal features, tolerance, and consequences, which leads to physical, psychological, functional, and social and financial. Abuse is common, but the drug addiction is rare. So there is a question, why don't everybody develop drug addiction? Why only some develops addiction? So let's glimpse the neurobiology and etiology of addiction. This addiction stems from a mixture of factors. It's a multidimensional construct with multifactorial causes. The adolescent brain is very sensitive to the environmental stressors. So the exposure plus vulnerability will lead to the maladaptive behavior. These vulnerable factors that adolescent brain is sensitive to the external stressors, externalizing spectrum of behavior, psychological abilities like predominantly poor executive control and reward deficiency, and emotional reactivity, rejection sensitive dysphoria, and emotional recognition. So coming to the etiology, as all psychiatric disorders are multifactorial, the same rules apply here. The alcohol use disorder is also biopsychosocial factors which influences the alcohol use disorder. If you see the genetic factor, environmental factor, developmental factor, neurobiological and mental health factor. Coming to the genetic predisposition, usually 40 to 60% of all addiction or alcohol use disorder is because of genetic predisposition. If the patient is having the vulnerability of the genetic vulnerability towards developing the disorder, so it will, along with that, vulnerable factors like environmental influencer factor that leads to the alcohol dependent syndrome. So if you see the environmental factors like substance exposure, peer group pressure, socioeconomic conditions, and addiction risk. You see the developmental factors like childhood trauma, childhood neglect, and childhood abuse increase the addiction risk. Mental health conditions like psychiatric disorder, personality disorder, ADHD, anxiety, depression leads to addiction behavior. And neurobiological factors along with the brain changes and the neurotransmitters will involve in addiction behaviors. So coming to the neurodevelopmental model, drug dependence is a pediatric disorder, as I said before, with the socio-economic origin, the genomic difference and epigenetic modifications that influence the development of addiction. The transition from the experimentation to dependence is governed by the complex interplay of exposure and vulnerability. Yearly stress alters the brain cells, dopamine glutamate imbalance, and long-lasting neuroplastic changes that reduces the pleasure response, increases the dose requirement, will lead to persistent brain damage. This repeated exposure to the substance will produce changes in the behavior, connectivity of the neurons, structural changes of the brain, and gene expression. So the people with the greater socio-economical and environmental adversity are at the highest risk. If you see the brain structure that involves in the substance usage or alcohol use disorder, all the abuse increases dopamine transmission. So in brain reward centers, the nucleus accumbens over the chronic stimulation will lead to neuroadaptation in the prefrontal cortex, the decision-making area, leads to switch from the impulsive to the compulsive area. The structure that involves a mesolimbic dopamine pathway, ventral tegmental area to the nucleus accumbens, prefrontal cortex regulation, limbic emotional memory, and neurotransmitters like dopamine, GABA, glutamate, serotonin, endorphin, and acetylcholine. So if you see the shift from the impulsivity to the compulsivity, so the adolescent brains are sensitive period where the limbic systems matures faster than the prefrontal cortex. So the area breaks for the decisions making and impulse control. This imbalance makes the teens more sensitive to the reward and less able to weigh the long-term consequences. So in early stages of alcohol use disorder, the impulsive use will lead to the pleasure-seeking behavior that leads to the liking, which gives a positive reinforcement to the substance use. The later stage is a compulsive use, the relief-seeking from the stress and drop, which leads to wanting and negative reinforcement. Compulsive behavior later become to the substance use disorder. This habit circuit dominates and leads to the loss of impulse control and poor decision making and heighten the response of drug associated cues and compulsive drug usage. Here are some of these theories that related to the addiction. One is psychomotor stimulant theory, incentive sensitive theory, apparent learning theory, frontostriatal dysfunction theory, and hedonic and allostatic theories. So all these theories focused on emphasize on the core mechanism of reinforcement learning, cue-driven behavior, information, loss of control, pressure to relief shift. So coming to the diagnosis of alcohol dependence syndrome, ICD-10. So the alcohol dependence syndrome is ICD-10 chapter 6 under the behavior, mental, and neurodevelopmental disorder. They have two categories. One is use of predominant of psychoactive substances, including medication, and addiction, specific repetitive, rewarding, and reinforcing behavior like gambling. So, diagnose the alcohol syndrome. There should be a pattern of or continuous use of alcohol with two or more symptoms. That is loss of control, salience, tolerance, withdrawal, repeated use of alcohol to prevent withdrawal feature. So, for a period of at least 12 months, or continuous use daily for at least 3 months. According to the DSM-5, the diagnosis of alcohol dependence syndrome requires these 11 symptoms can be categorized into 4. The criteria is impaired control over the substance. So, more time drinking than it want to limit or suffer. 3 symptoms comes under the group.
There is some internet problem, I think.
Screen has gone.
When the physically danger and continue use in despite of knowing its harmful effect. And group D's are pharmacological symptoms. That is, one is tolerance, other one is withdrawal features. So if there is 2 or more symptoms present, it is considered as a mild. The presence of 4 to 5 symptoms, it considered as a moderate alcohol
You
use
might
disorder.
need to
If it is more
screen
than
share
6,
again. You might
Yeah.
need to screen share again. There is some problem. The screen is not being seen anymore.
Now it's coming, sir.
No, not as yet.
Share again, please, sir. No, it is not.
Okay. Yeah.
Yes, yes.
Yeah. Please do full screen, sir.
Let's
Yeah, correct. Yes, please.
Sir, whenever the interruption is there, please let me know, sir. Because in the mobile, a
Yeah,
lot of
yeah.
phone calls are also
Sure.
coming, so I couldn't be able to catch it
Yeah,
on.
yeah, please go ahead, sir.
So now coming to the DSM criteria, withdrawal syndrome. The syndrome develops the twice decrease or stopping of regular heavy drinking, accompanied by development of at least 2 of the symptoms: increased pulse, tremors, problem with sleeping in the form of insomnia, gastrointestinal upset, hallucination, inability to sit still, nervousness, or seizure. So, for a period of time, about 8 to 8 hours to maximum of 14 days. So, other in psychotic disorder due to alcohol, alcohol-induced bipolar disorder, depressive disorder, anxiety disorder, sexual dysfunction, mild cognitive disorder, and intoxicated delirium or withdrawal delirium. So, why we need assessment? So, full assessment requires holistic and neuroclinical approach in performance or measure to gauge the executive function, emotionality. The goal is to address the entire spectrum of the disorder. Indian population in numerous ways, that is include screening the patient who may present with only a physical problems but do not reveal substance use biomarkers. So establishing the diagnosis, planning for the treatment, referral to the specialist if needed, assessment itself is serve to establish the rapport and motivate the client to remain and to adhere to the treatment and reduce harmful use and abstinence. So the assessments falls into three categories. One is clinical assessment and laboratory investigations and assessment through the psychometric tools. So if you plan for the complete detailed history taking is must in order to have a complete alcohol history. It includes specific questions concerning about the alcohol consumption, maximum consumption per drink, and the frequency of alcohol usage, and related social problems, family stress, and at workplace, legal problems, and alcohol-related medical problems like gastritis, abdomen pain, pancreatitis, melena, jaundice. So all the symptoms will be covered. Collateral, family history of alcohol use and psychiatric illness has to be covered. Past history of any abstinence attempt, past treatment response, head injury, hepatic, respiratory, or cardiovascular, or other infection, if they are treated, it has to be covered. So general examination, thorough, head to toe, general examination has to be done. Systemic examination involving all systems like central nervous system, cardiovascular system, respiratory system, and genitourinary and gastrointestinal system has to be examined thoroughly, because alcohol leads to much of the other medical comorbidities also. So coming to the laboratory findings, we have to have a complete blood investigation, which includes a complete blood count, renal function test, renal function test, serum electrolytes, and random blood sugars. These are some of the state markers I have shown in the slide. Some of the state markers of alcohol are discussed here, and carbohydrate deficiency transferase. This is a specific marker. It is superior above glutamate transferase, and it is ranges more than 3 milligram per deciliter. It's found to be significant, and it indicates that the recent intake of heavy use of alcohol, that is more than 60 grams of alcohol for a 2 weeks duration. This test is less sensitive but more specific to the alcohol abuse, and it will take 2 to 3 weeks of abstinence to return to the normal range, and it helps in monitoring the abstinence and check the relapse. Coming to the GGT and trials, it is raised in about most of the cases. It is above the more than 40 international units is considered to be significant, and it's about 80% of the alcohol dependent individual. The GGT remains to the normal or rapidly within 48 hours from the abstinence from the alcohol. These blood tests have been more sensitive and less specific, and it helps in diagnosis that alcoholic liver diseases and excessive intake of alcohol. The other investigation I would like to mention is the SGOT, SGPT. In most of the cases of excessive alcohol usage, the liver enzymes will get elevated, and the mean corpuscular volume increases due to the heavy intake of alcohol. And ethyl glucuronate in urine is a sensitive method to detect recent consumption of alcohol. So the abstinence can be monitored, the presence of ethyl glucuronate in urine for 3 to 5 days. So ethyl glucuronate in hair is also a sensitive method to detect the recent consumption of alcohol, but this remains positive up to 90 days, and the significant value, if it is more than 30 picogram per milligram, is an excessive usage. And free fatty acid ethyl esters in alcohol is also a sensitive method to detect the recent consumption of alcohol. This remains significant for 3 to 6 months. And up to 90 days. So other investigations that will help to find out the alcohol use disorder, there is a decrease in albumin, that is hypoalbuminemia, and increased uric acid level more than 6.5 per milligram. Hypomagnesemia will be present. The evidence of bone marrow suppression is in the form of decreased B12, decreased folic acid, megaloblastic anemia, and low platelet count. And blood and urine alcohol level is helpful in assessing the withdrawal state. And for the legal procedures, breath alcohol test can be done. The pancreatic level will be elevated in some cases, whether the pancreatitis has been associated. So USG abdomen is needed, and the radiological investigation for the brain, chest, and abdomen on the required basis. Coming to the psychometric analysis, it helps in quantifying the symptoms and weigh the severity. So also help in initiation of the treatment. So where to treat and like which place to take, whether the patient has to be treated inpatiently or community based, depends upon the severity of this psychometric analysis. So the audit is alcohol use disorder identification test, most commonly used scale, and it's a 10-item scale developed by WHO on the alcohol consumption. Maximum score is 640 and the minimum score is 0. So first 3 questions quantify the alcohol consumption. Next 3 questions signs and symptoms of dependence, and next 4 questions related to the behavior and symptoms that associated with harmful alcohol use. If the score is between 8 to 14, then it is hazardous, and 16 to 19 is harmful drink, and more than 20 is alcohol dependence. The second is severity of alcohol dependence questionnaire, and it's find out the severity of alcohol use. Detailed 20-item question is the self-administered screening tool to measure the patient and the severity of the dependence. Maximum score is 60. If the score falls less than 15 is mild, and it is score between 16 to 30, then it's moderate, and if the score is more than 30 is severe. So I personally use the SAD-Q questionnaire in order to treat the patient according to the mild, moderate, severity. The CAGE questionnaire is the primary health physician's questionnaire of screening test used for the alcohol dependence syndrome. So it consists of 4 questions, and total of 2 or more considered to be significant. Higher the score was in the mass, again it's a 25 item questionnaire, self-administered, and 0 to be no apparent problem, 3 to 5 yearly or middle problem drinker, and 6 or more is a problem drinker. SIVA again is a withdrawal assessment scale. The score is less than between 8 to 10, then it's mild. 11 to 15, it's moderate. If the score is more 15, it's severe. And short alcohol withdrawal scale is more than 12 is found to be significant. So coming to the management. So treatment of alcohol use disorder includes intervention, detoxification, relapse prevention, and rehabilitation. So the goals, what is the goals of the management? So we have to have a short-term goal and long-term goal. In the short-term goal, we have to focus on intoxication symptoms and withdrawal features, treat the acute medical sequelae, and crisis intervention, motivation enhancement. So as a long-term goals, relapse prevention, maintain the abstinence, occupation rehabilitation, social integration, and ultimately to improve the patient quality of life. So no single treatment is effective for the individual. So we need to tailor according to the patient. So always pharmacological and not social intervention is always better. As a patient, the post-treatment environment and continue for the treatment plan. And involuntary acceptance of the treatment have some outcome depending upon the skill of the therapist. Coming to so intervention is a process aimed to increase the motivation as regarding the treatment and continue to remain absent. A discussion of their presenting complaint can be very useful to show the empathy and enhance the motivation to change. So here are the Procasco and Declament's classification of staging of motivation. So there are 5 stages. In pre-contemplative stage, here the patient do not consider for a change, they let the drinking behavior persist. So what will help here is we have to give an information about the client and their problems, help the patient to ventilate their feelings and about the problems and impact of the problem on the patient and around the people. So what the psychiatrist can do is confrontation, psychoeducate about the alcohol and focus on the rapport building, encourage and appreciate whenever they desire to quit the alcohol. So in contemplation stage, the patient consider acknowledges that there is a problem, but the cost and benefit of change the drug taking behavior persist. So what will help here is assess the client feelings and cognition about his drinking behavior. So what therapist can do is facilitate the analysis of the pros and cons, help them to realize and appraisal of the good and bad things about the alcohol using behavior. In preparation stage, patient will be ready to quit alcohol using behavior. So what will help here is choosing and giving up the drugs and commit to specific goals. So reaffirm the ability to make the changes. So in action plan, in action stage that takes action to stop the drinking behavior. What will help is achieve the goals by taking the concrete steps, and the therapist has to help him to identify the definite plan for action. So in the maintenance phase, there is a sustained and modified behavior to remain abstinence and drug-free life. So what will help is continue to take steps to strengthen these commitments to give up the alcohol. So psychiatrist has to try to involve and significant others like alcohol anonymous groups. So coming to the brief interventions. So this is by Esther and Miller. 6 ingredients are to induce changes in the problem drinkers. So when a person of alcohol use disorder comes to the clinic, first the screening has to be done and they assess the motivation stage, whether he is in which stage, and what the clients is needed. According to the client's need, the therapist has to expertise the personalized strategy to give the responsibility, advice, empathy, and self-efficacy that is offered in non-judgmental and supportive way. So coming to the motivation interview, developed on the understanding regarding the consequences and regarding the ill effect of the alcohol use. So explain the benefits of changes, the behavior, the recognition of ambivalence of the patient towards the abstinence, shows sensitivity towards the readiness of the patient to change. The resistance can be managed by discussion and problem solving rather than criticism and confronting. Exercise, ask the patient to keep a book for noting events between the visits which the response occurred or could occur. So the basic principles are avoid discrepancy, avoid argument, roll with the resistance, and express empathy and help the support self-efficacy. So the 3 phases of motivation principles are: one is building motivation for change, strengthening the commitments, and follow-through strategies. Coming to the cognitive behavior therapy, primary focus on the individual thoughts and the behavior. This therapy is based on 3 theories of substance use, namely relapse prevention, cognitive therapy, and behavioral learning therapy. The CBT is structured and directive, focused, time-limited approach, and has strong empirical support for the use of treatment of alcohol use. So the general principles is emphasized on the functional analysis of the drug use within the context of antecedent and consequences, the skill training through which the individual learns to recognize the situation, avoid those high risk or risky situation whenever it is possible. So after the intervention, so we need to decide whether the patient has to be treated communitally or as an inpatient. So the psychiatrist has to select the place where the treatment is required, with all the collective information from the history, laboratory investigation, and the psychometric tools. So here are some of the points to consider the community detoxification. One is there is a supervising care, ideally 24 hours a day throughout the duration of detoxification is available. Then the treatment plan has been agreed with the patient, the carer, and general practitioner. The contingency plan has been agreed with the patient, their carer, and the general practitioner. The patient is able to pick up medication and be reviewed professionally throughout the process of the detoxification. Outpatient and community-based program in psychosocial support are available. If the community detoxification should be stopped if the patient resumes drinking or falls engaged in the agreed treatment. Then it has to be, then the patient has to be as inpatient. Okay. So if the patient wants to be treated inpatiently, then the regular consumption, if patient having a regular consumption is more than 30 units per day, and SAD2 is more than 30, or audit is 20, or SIVA.
I think you need to reshare the screen.
Yeah. Got disconnected, sir. Shortly you will be sharing.
I think the speaker has
Some technical glitches, sir. They are
Yes.
resuming.
Yes, sir, please.
Yeah, please, sir. And full screen mode, sir.
We have about 5 minutes left, sir.
Sir, your audio and video is not coming. Kribakar Krishnan, sir. Your audio and video is not on. Yeah,
Yes, now
only
the
your
audio is
audio
on.
Yeah, now audio
The
is
audio
on, sir. Yeah,
now it both is okay.
yeah. Audio is
Yeah,
on,
okay.
sir. Yes. Yeah. Video also
Audio
can
is
be
on.
open,
So
sir.
now the choosing the long-acting benzodiazepine or short-acting benzodiazepine depends upon the patient's profile. If the long-acting agents is preferable, it will be a smoother withdrawal course, less breakthroughs of symptoms, prevent seizure and delirium. If you want to prefer the short-acting agent, the liver dysfunction is there, elderly patients on respiratory depression, the short-acting will be preferred. So these are the preferred drugs for the detoxification. So one standard drink, that is 30 ml of alcohol or 10 grams of alcohol is equivalent to 5 milligram of diazepam, 25 milligram of core diazepoxide, 1 milligram of lorazepam, and 15 milligram of oxazepam. In that, long-acting drugs can be used for the smooth withdrawal symptoms, and short-acting drugs preferably is used for the patient, those who are having hepatic dysfunction. So this is the fixed dose regime. The fixed dose regime, only the SAT-Q questionnaire, if it is severe, then we have to start with 40 milligram QID or 5 times a day of chloride diazepoxide, maximum dose of 200 milligram per day, and each and every day the 20% of chloride diazepoxide is reduced until the patient reaches the asymptomatic level. If the patient is having mild degree of SADQ, moderate severity, then the patient can be treated with 80 milligram of chloride diazepoxide in the first day, and rapidly 20% of the chloride diazepoxide of the previous day is reduced, and until the patient free from the symptoms. So trigger symptoms regime can result only for the assisted withdrawal. Here the regular monitoring is required. 25 to 30 milligram of chloride diazepoxide hourly is needed to assess along with the SIVAs or short alcohol withdrawal scale. The pharmacological therapy continues as to the patient is having withdrawal symptoms. This front-loading regimen is only to the patient who have high dose of medication followed by fixed dose regimen and symptoms regimen. Usually 30 to 40 milligram of diazepam is used as a front-loading method, and following that the patient is shifted to the fixed dose regimen or symptoms regimen. So the individual alcohol-induced psychotic disorder has to be taken care. If it is in a psychotic disorder, antipsychotic is helped, especially sulfurides, anisulfuride, paliperidone, clonazepam, haloperidol, antihistamines are found to be useful. So caution on using the bipolar disorder has been taken care. It is not sharing. Sir, shade is clearing, sir. Yeah.
We are
Yes.
able to see the slides, but we have limited time now. So maybe
Sir, okay, sir.
5 minutes more.
Yes, sir. Coming to the nutritional supplements, sir. Sir, actually, because of the technical problem only, it is getting delayed, sir.
Yes, please continue.
Yeah. So what after the detoxification? So plan for the long-term management. Pharmacological agents like stimulant or anti-craving, non-pharmacological like motivation enhancement therapy, relapse prevention therapy, group therapy, and family therapy can be. So the pharmacological therapy is no place for continuous use of benzodiazepine beyond the treatment of acute withdrawal syndrome. The factors to be considered: the patient preference, prior response to the drugs, look for the contraindication or comorbid conditions. So initially the detoxification, once the detoxification is completed, we can use disulfiram, acamprostat, naltrexone. So it is not found to be an efficient. So combination of the other pharmacological or off-label second line therapy can be used: baclofen, topiramate, aripiprazole, gabapentin.
I think screen sharing once again, Dr. Saab, is off. I think it is 8:50. We have covered the major part of presentation.
Yeah. Please
So
share the screen, sir, and open your video also, sir.
Technical support has to be given in early.
Yeah, I have asked you to start the video. Please start. I have stopped you because your network is very low. So that's why I have stopped your video.
Yeah, please.
Okay, sir.
Yeah, it is visible now. Yes.
Yeah, okay, sir. From in the slide early. So the adjunct therapy, sir. So why do we need an adjunct therapy in the alcohol dependence syndrome apart from the main line of treatment? Sir, audible, sir?
yes.
Audible.
Okay, sir. Sir, okay. So why this adjunct therapy is needed? The therapeutic intervention is added to the primary treatment with the aim of enhancing the efficacy, treating the residual symptoms, improving the tolerability, targeting the psychopathological mechanism not addressed by the first line of drugs. So example, N-acetylcysteine, omega-3 fatty acid, and L-carnosine. So we will have a slight overlook on L-carnosine, sir. So L-carnosine alcohol use is oxygen species, which in order to produce the oxidative stress and damage to tissues. So it interferes in the lipid and nucleic acid metabolism, leads to fatty liver, hepatitis, and cirrhosis. So nervous system is also very sensitive to the free radicals. That increase in the free radicals leads in excitation by increasing the glutamatic activity that alters the neuroregulation, neuromodulation, immunomodulation, and induction of apoptosis. So the L-carnosine is found in muscle and brain. It's known for its antioxidant, anti-inflammatory, cytoprotective, and free radical chemical properties. So endogenous antioxidant response of the organism are activated through the transcripting factor of NRF2, which regulates the reactive oxygen species and thus reduces the tissue damage. So L-carnosine is a beta aniline and L-histidine is a chemical which is the neurons and it has ability to penetrate the blood-brain barrier also hepatoprotective, tests the LDH activity and normalizes the protein concentration and improve the liver function test. So L-carnosine supplement reduces the pro-inflammatory cytokines, CRP, interleukin 6, and tumor necrosis factor alpha, and down-regulated the inflammatory gene expression. The dosage is again for the alcohol use disorder, 1.2 grams per day in divided doses. Usually it comes in 200 and 400 milligrams, and it's available in syrup form also, I think so. So if we consider the higher the dose, that is more than 1,500 milligram dose per day, the nausea, gastric fullness, loose stools, headache, dizziness, and fatigue will occur. The caution is required in the renal diseases and those with seizure-prone patients. So pregnancy and breastfeeding, limited dates are available. So the influence of antioxidants, there are some studies I have been focusing, sir, and all these studies shows that there is an effective of recovery of blood level of aldehyde transferase and aspartate transferase, myeloperoxidase, and malonic acid. And morphological damage of hepatocytes is found to be improved, and exogenous carnosine have priming effect on endogenous carcinoma and provide the action in reducing the oxidative stress and prevent tissue damage. So what are the things? They address the patient of post-treatment environment, identify and handle the situation, refusal skill and assertiveness, deal with the faulty neglection, faulty cognition, negative mood, and balanced life. The role of the family is very, very important. Advise them, psychoeducate them, do not suspect and doubt about the behavior of the patient, extra attention to be paid to the nation, for the nutrition and the medication, and do not discuss the previous drinking pattern. The follow-up is necessary for the alcohol use disorder because the relapse rate is more. The first 3 to 6 months, there is a frequent follow-up is needed, and identify the relapse events and strengthen the patient's ability to handle the situation effectively. And whenever need, the bed analysis has to be done. The self-help group is found to be important, and this supports the family members and approach in many ways to resemble the cognitive behavior therapy. So the challenges of alcohol use disorder is poor treatment, retention, and follow-up in for patient side. The efficacy of the treatment is the patient's characters. The personal characteristic of therapist affect the outcome. So matching this expectation, multidirectional approach is good and effective. So finally, to conclude, alcohol dependence is a complex, multifaceted conditions required long-term care, not a moral failing. Understanding the cause and consequences and treatment option is crucial for the development of effective prevention, intervention, strategies, and treatment approaches. Alcohol use disorder is a chronic, relapsing, and remitting disorder. Thank you.
Thank you, Dr. Kruparkaran, for a very erudite talk on alcohol use disorder. It's certainly very useful, and I think we have all benefited. I would now invite the questions. Mr. Raj Manakam has some questions from the audience. Maybe I can start with a question for the speaker.
Yes, sir.
In your opinion, give us the clinical evidence for L-carnosine being effective for alcohol use disorder.
Yes, sir. So the clinical, as per my personal experiences, sir, I have seen the person who has been prescribed with L-carnosine, their enzyme level is getting settled and remitted within a few months of starting of L-carnosine, sir. And there is a literature evidence that has been done from the Russian part, that the slide has been not able to flash it that. So it also proves that the L-carnosine in the using of L-carnosine 1.2 grams for 30 days of duration in the patient who is in remitting and rehabilitation period is found to be increased in the response and a decrease in the symptoms of insomnia and other reduction of symptoms and increase in the especially in the liver function test. It has been proved, sir.
Okay, thank you very much for that. Mr.
Audience question shall I post, sir?
Yes, please.
Yeah, there is a Dr. Syed has asked a question. In management of aggressive patient under acute intoxication state, should go with benzodiazepines or can we use haloperidol?
But actually, the patient, if we have to see this, patient is going for a violent patient, whether it is due to the alcohol alone or the patient is having psychiatric features like or patient is in a delirium state. If it is an alcohol-induced condition, then the benzodiazepine 5 doses is found to be useful, sir. In some literature, it says that low dose of antipsychotics is also found to be useful, sir.
Fine, sir. And another question, there is a doctor, psychiatrist has asked Dr. Archana. He has asked, I have seen some of my colleagues psychiatrists are prescribing UDCA in ADS. What is the indication or regularly prescribed or how long it should be used?
Now, actually, the medical comorbidity most commonly encountered in alcohol use disorder is hepatitis, sir. So the liver function test alteration will be there. And most of the physician, what they used to do, they will go for the UDLIV or UDCA for a certain period of time. Once the liver enzymes is found to be normal or getting down or settling, then the role of UDCA and UDLIV, the tablet for the hepatitis can be stopped, sir. And the patient has to be put on to the regular anti-craving and deterring agent in order to prevent further intake of alcohol and leads to the severe damage.
Okay, it is a kind of supportive therapy they are using, like that. Okay,
Yeah, sir. Yeah.
And there is one more question from Dr. Archana. Should we prescribe L-carnosine regularly on the patients with impaired LFT?
Sir, actually, I answered to the previous question itself. This L-carnosine is actually an adjuvant therapy. The studies has shown that a lot of cases the liver function test has improved and the resistance to the hemolysis also significantly improves compared with the N-acetylcysteine, sir. So this L-carnosine usage is mainly depends upon the patient profile. Whether the patient is able to afford it, then we can use it. There is no harm in that. If the patient is unable to afford, then we can use it until the other blood parameters came to the normal. Till the time we can use it, sir. There is no hard and core rules that we have to use it, the L-carnosine for a certain period of time. This is up to the patient profile and the treating psychiatrist interest.
And that is what they've asked, how long it should be prescribed, what is the dosage regimen we have to use? Another question, counter question on the same.
Dosage regimen, if you want to use L-carnosine, actually the literature says that the studies, they have quoted 1.2 milligram. Actually, this dosage comes in the form of 200 and 400 milligrams. So it can be given in divided dose in like 3 times a day. We can give it for a period of a month, and we can again the blood investigation has to be repeated, and we will ask for any liver function test specifically if needed. And if we found there is an improvement, then we can continue, or if there is an improvement, we can stop it, or if further if needs, then we can continue, sir.
Yeah. As of now, there is no more questions from the audience, sir. There are 4 questions only. I
think it is 9 p.m. We have had a wonderful
Yes,
talk on alcohol use disorder and recent concepts. The speaker has highlighted the importance of a structural approach towards alcohol use disorder. He's talked about the etiology, he's talked about the complications, then he's talked about the management principles. He's given a lot of importance to the psychotherapeutic aspects. He's also talked about the audit of alcohol use disorder, both for assessing the severity and for the treatment by using standardized tools like audit, SIVA, etc. Then he's focused on the management or primarily the use of benzodiazepines in the treatment of alcohol use disorder. And last but not the least, he's talked about prevention of hepatic damage or secondary and primary prevention, sometimes tertiary prevention, by use of a novel agent for oxidative stress, L-carnosine. The question answers also highlighted that L-carnosine might play a very important role in prevention of liver damage. So I think with that we need to conclude, and thank you very much. The entire audience has been very encouraging. Thank you very much. We have had some glitch as far as the screen sharing is concerned, and we apologize for that. Thank you very much.
Thank you, sir. Thank you very much.
Okay. Good night.
Good night, sir.
On behalf of Linux Laboratories, thanks to the audience and the chairperson, Dr. Rajesh Nagpal from Delhi, and Dr. Kribara Krishnan from Madurai, speaker. Thank you very much.
Thank you, sir. Thank you. Technical support full.
Yeah. Technical.